pull it to the computer, and then we'll hit share screen. And then I've got here. Okay. All right. So first slide, immune defenses against tumor cells. A concept known as immunosurveillance. The immune system patrols the body for cancer cells and destroys them before they become clinically evident. And you know that's ongoing, and we hope that that it's working, that our immune system prevents some of the cancer cells from developing and continuing to develop if there has been a mutation and your immune system has picked it up. So that is what we look at as immune surveillance. So a protective mechanism. And then we have our immune defenses against tumor cells. So looking at page 294, I'm going to do it this way right now. And you have this big picture from your book. If you took the tumor cell in the middle and look at all the different ways that our immune system that you've learned this whole semester, how it attacks a tumor cell. So you see natural killers, you see cytotoxic T cells, you see T helper cells. Hopefully all this is very familiar to you. Antigen presenting cell, the B lymphocyte turning into plasma cells and producing antibodies. So every part of our immune system, and hopefully you see a MAC formation up there for complement, that you see the whole, this is the summary of your semester all in one picture. And it should now, hopefully you can understand what's going on. Hopefully we've covered it that way. That was our goal of the semester, was to cover the immune system so you would understand this picture. Good. So the innate immune responses, is natural killer cells and macrophages. So we have those two. We have those two sitting up there surrounding the tumor cell. You know that natural killers are lymphocytes, and they have no, they will just go after something without a lot of help, right? So that's the innate, what we're born with. And of course the macrophages are in areas that they're needed when we think of external antigens, but now we're thinking internal antigens, right? When we think of a tumor cell. Oops. The adaptive immune response, the cytotoxic T lymphocytes, the CTLs, dendritic cells, cytokines, and antibodies, all of those playing a role in this. You see tumor necrosis factor. We see ADCCs. We see some major histocompatibility, unrestricted and restricted. We see perforins being produced. Apoptosis there with cell death and lysing of the tumor cell, different ways of attacking it. So this is also from your text on 297, relationship between the immune system and cancer. So this is how a tumor cell may stay when we think of equilibrium. We think of a tumor cell even escaping the immune system. So we've got going from blue, green to red. So the elimination phase, this is what we're hoping. We're thinking this is ongoing. This is that surveillance we think is happening. Robust, innate, and adaptive immune response kills most tumor cells. So that's great, right? That's what we're hoping when we come into a chemical that causes a mutation, whether it's inhaled or ingested, but maybe our water. When we think of chemicals on our food, when we think of chemicals in our meats that we eat, just from walking outside and walking behind a car while we exercise. That's one of the, one things I've always thought about running in a city is that if you got to run down the highway, you're ingesting, carbon exhaust into your lungs, and that can be a problem. So tumor cells identified by the antigen and the MHC1 induce the apoptosis by FAS ligand. And I know y'all are wanting to know what FAS ligand is. Or at least I am. We see it again down at the bottom in the equilibrium stage. We see FAS again. And
it's a type 2 transmembrane protein that belongs to the tumor necrosis factor family.
Yay. Okay. Thank you, Allison, for that. Equilibrium, the immune system controls a limited number of altered cells. So to escape the elimination phase, a tumor cell may alter itself. It kind of does a genetic mutation. And it's fast growing, so that mutation takes effect really quick. The tumor cells are dormant and they begin to lose or mask identity features. So, hey, you know, I had all this, you know, up here, and the immune system was able to eliminate it, but there may be a survival cell, right? When we think about, did we get it all? Has it started to circulate? Was it metastasizing? And maybe that new cell is mutating so that it does evade the immune system. And then lastly, escape. The immune system is suppressed. Chronic inflammation promotes tumor growth. So we think of chronic inflammation, we think of autoimmune disorders, we think of rheumatoid factor, where the immune system is suppressed, so it can't take care of a tumor cell like it normally would. And tumor cells highly are altered at this point, more resistant to immune responses, and apoptosis is impaired. So just like a virus, a cancer cell can undergo mutation and decide to change what has been bad for its survival, and it becomes, as you want to say, evolves into a better cancer cell that now can evade the immune response of our own. So we lose our ability to eliminate these cells. Any questions on those three: elimination, equilibrium, escape?
I have a question regarding mutations. So like, how fast does it undergo mutation? Is it like an instant mutation, or does it take like weeks or years?
Weeks or years? Well, I think there was a sniblet coming up on, I think it was with, I don't want to give you the wrong spot, but I know it was with, I think it was with the vaccine, the active immunotherapy with cancer vaccines. It kind of gave you the idea of the tumor cell being mutating. I was trying to think. I think it gave an idea. Great question.
It's kind of off topic.
No, it was. It's on topic because I read through it. They were talking about the vaccines for cancer. Tumor cells lyse whole tumor cells inactivated. Unfortunately, clinical trials found killed tumor cell vaccines did not have a significant effect on patient survival. Generally, I was thinking, I know I read it. Oh, we'll come to it. No, I'm not thinking years. I'm thinking if a cell survives, I'm thinking it happens quicker than we think. But this dormant idea of it lying dormant and going into tumor cells begin to lose or mask identity features. So when we think of HIV, that would be over years. But I don't think the mutations would be active at that point. So I think what we think of a mutation occurring quickly and then allowing that virus to lay low when we think of HIV. So I would think the same for the tumor. But let me look, let's see. This immunoediting, as a result of tumor cells escape, it really doesn't give a time. So I'm not, that is something we'll have to look up. Anybody else read over a time period for changing?
I feel like it would maybe depend on the type of tumor, or like it would rely on a lot of factors.
Okay.
Because like with HIV, you said it goes dormant. That could happen over years, but like there's some cancers that, I don't know, they happen fast, right?
Right.
So it would make sense that it was just like circumstantial for each thing.
Yeah, I would think once, I mean, just think if a point mutation happened, I would think it would be quick. I don't think it would need time to wait. It wouldn't survive. So, you know, a cancer cell circulating, the immune response is attacking it, you know, aggressively. I think the point mutation would allow it not to express something quickly, and then it divides from there. So I think the point would happen quickly. Now, whether it would be able to build up quickly, I would think so. You know, I would think as long as it was avoiding the immune system. And we think of that, you know, we can go back to our bacteria, we can go back to our viruses, but I think cancer is a different ball game when it comes to the way they can divide quicker than anything else. So they are aggressively growing quicker. But that is a good point. We'll have to look at that one to see how quick immunoediting occurs, because that's what they're saying. The term is immunoediting for this. And it really doesn't give a time. Elimination tumor. The immune response is not completely effective. Some tumor cells remain in the body. The immunoediting hypothesis suggests that the cells then enter the equilibrium phase. But it doesn't give a time. I don't see a time. It just says if it makes it through the elimination phase. So we'll have to come back to that if we don't get it before we end today. So that being said, immunotherapy. So this is, you know, we think of the the immunology being used against what we know about the immune system, and this is why you're in this class, is to learn more about the immune system, so you'll understand what immunotherapy is all about. So biological response modifier therapy, we use the immune system to destroy tumor cells by what we know works, what the immune system has showed us, how it attacks different things. We can use that knowledge to work on the patient. So we can stimulate the patient's immune system to respond to a tumor antigen, kind of like, you know, if we know what they have and we know what marker works best with the immune system, you know, maybe we give that antigen to the patient and get the immune system revved up more to try to eliminate or to attack. So there can be point attack, like if you have a tumor and you know what marker is there, we can send in antibodies for that purpose. Non-specific stimulation, Coley's toxin, and BCG. And that BCG is for micro. What does that stand for? Bacillus calmate guerion, okay, from 298 is where we are. And it's a live but weakened strain of Mycobacterium bovis bacteria. And it is considered to be the treatment of choice for non-invasive bladder cancer. So using a mycobacterium for bladder cancer, what it is the treatment. You directly deliver it into the urinary bladder through a catheter, and it's shown to be effective in reducing the progressive tumor growth and delaying recurrence of the cancer in these patients. The exact mechanism is unknown, always, right? But it is believed to stimulate cytokine production by macrophage and activated lymphocytes, increase increase anti-tumor effects of macrophages. So putting a Mycobacterium bovis into the bladder, the body actually responds and kills the tumor. So, wow, right? So that is a non-specific stimulation where we use something obscure. Now, how we ever realized that was probably some cancer research. Somebody, I don't know, by accident or by thinking, but put in a mycobacterium in there to see if we could get the immune response to work. The cancer vaccine is kind of what we've seen this with HPV, the human papillomavirus, and HPV, the hepatitis B vaccine, where we use, we give the body a vaccine of a virus, right? And if we have HPV, human papillomavirus, is eliminated and we prevent that from occurring and setting up shop, that's going to prevent cervical cancer. Okay, so that's the connection there. And most of us at your age, if you get exposed to HPV before the vaccine, then you're at risk for cervical cancer. Passive immunotherapy, this is we give things of the immune response. I mean, we give parts of it. So we administer soluble components of the immune system, cytokines, okay, to non-specifically boost the immune response and increase white blood cell production. We see some of our familiar faces here: interferon alpha, interleukin-2. That is that colony stimulating factor? What is GM-CSF? It's not cerebral spinal fluid. What is CSF?
Isn't it colony stimulating factor?
Yes, it is. Just checking. So we can actually administer interferons, okay, alpha. So we can give the cytokines. So definitely something that would boost the immune response in an area of a tumor. Definitely we could use immunotherapy. Monoclonal antibodies, this is kind of the cool thing. Monoclonal antibodies that target specific tumor antigens. So we take a patient has a tumor and we grade it out, we know what it is, and then we can actually look to see if we have a monoclonal antibody that is targeted against that tumor. And this is, we're giving you the antibody. That antibody goes in and starts to bind to the tumor, and that brings the immune response to the area, just like it would if it found the antigen and we produced our own antibody. And then since it's monoclonal antibodies, we can give this in large doses. We don't have to, wait on our body to produce these. These are specific targeting the tumor antigen. So this is, we've seen this already. We saw this with autoimmune disorders, where we were giving, monoclonal antibodies to go after the bad B cells that are overproducing an antibody that's causing, say, an autoimmune response. So the same kind of principle. So monoclonal antibodies, we have that feature. Table 17.5, we have some of these, and I don't know if I have 17.5, doesn't look like. 17.5, you've got approaches to cancer immunotherapy using monoclonal antibodies. So these are some of our familiar names, those that have been paying attention to our antibodies. So the first one I see up here is a surface antigen on tumor cells. So that's our first dot. And the mechanism of action is opsonization, complement-mediated cytotoxicity, and ADCC. And what was ADCC again? That should be automatic on your vocabulary list. I think Sharugs have to answer that a few times for me in class. ADCC?
Okay, so it's antibody-dependent cell-mediated cytotoxicity.
Yes.
There we go.
All right. Say it one more time so they can remember it this time.
Okay. Antibody-dependent cell-mediated cytotoxicity.
Yes. Okay.
Hard.
All right. So the drugs, examples of a surface antigen on tumor cells, some of these monoclonals that we're using. Rituximab, remember we've had that one. My wife's had that one. You know, I had to figure out a way to pay for that at one time. It's expensive. Each dose is about, let's see, what was our dose? What was our expense? I want to say we were looking at 4 doses at $15,000. If you want to know. The one thing I'll leave you with, I think I've already said this once, but leave you with the idea that these companies that make these monoclonals and the doctor decides to use them against one of your, say a cancer, a new cancer, they're willing to give you that drug for basically put you in their studies. What they want to do is see the results of that so that the next time they see that it's effective against whatever they went after. But rituximab, monoclonal antibody directed against the CD20 antigen on B cells. It's used to treat B cell neoplasia. So if you got a B cell issue, you got an overproduction of B cells, or you got the wrong B cell, what that does is this antibody goes in, attaches to the B cell, and then elicits a phagocytosis and the destruction of that B cell. So it's very, very scary because what they'll do is they'll put you on steroids during this time, and they will ask you hopefully not to get sick because you put yourself in an immunocompromised state with steroids and another taking a drug that's going after B cells. So you're losing the ability to produce antibodies, but hopefully you're eliminating the wrong B cell, the B cell that is a problem. So that's rituximab. The other, and what did we say on the mAbs? We got IMAB, UMAB. I see those so far, and just kind of review from the others. What does all those mean? Remember, there was a key to the monoclonals on their names. Just to review, because you're gonna have a final coming up in a couple of weeks. Alemtuzumab is a monoclonal directed against the mature lymphocyte antigen, CD52, used to treat chronic lymphocytic leukemia, CLL, and T-cell lymphomas. So again, highly used monoclonal antibody. Anybody come up with the key again for the names of the UMABs, the IMABs, and it has something to do with their sources, doesn't it? With the model we used, or if it's, what was it? It was human versus. Anybody out there? I see Allison working very hard. Sharug's looking. Anyway, when you get it, just interrupt. We're going to move on to cell surface receptors. Here, the mechanism blocking signaling pathways involved in cell proliferation and survival. So we have what is that? Panitumumab, directed against epidermal growth factor receptors used to treat colorectal cancer. Trastuzumab, directed against HER2 gene, that's that breast cancer, treat breast and gastroesophageal tumors and overexpressed HER2. We got antigens involved in angiogenesis. They inhibit the formation of blood vessels necessary for delivery of oxygen and nutrients to the tumor. And if you don't know much about tumors, they will intertwine into the they will find a way to get to your circulatory system so they can be fed, and they will be highly perfused. So they will increase your blood, the vessels that grow around it and intertwine into their way of getting the best out of the blood before anybody else does. So they're evil, alien acting things that take over. That one is bevacizumab, directed against the vascular endothelial growth factors for treatment of glioblastoma, colon, lung, and renal cancers.
I think I found the chart that you were talking about.
You did?
It's on 469.
469. Okay, let's run over there with our monoclonals. Remember, we had that, we ended up to the back of the book, but now we're coming back the other way.
Yeah, the humanized antibodies are denoted by the suffix zumab, and chimetrics are by iximab, and then it has a chart that lists whether it's humanized or chimetric and then what it like goes against.
Thank you. And chimetric is
It's a good question.
oh, y'all are supposed to already know that. What is chimetric? Chimeria, right? What is, there was one, where was it in the, is it in the summary?
They consist of a mouse-derived immunoglobulin variable region combined with a human-derived consistent region.
Yes, there you go. Thank you for that. Thank you for that review. That was chapter, what chapter? .469. What chapter is that, Allison?
Chapter 25, immunizations and vaccines.
Chapter 25. All right. Thank you. All right. So we have molecules that block T cell activation. All right. So that that sounds counterproductive. I just reading it right off the bat, right? Molecules that block T cell activation and proliferation by binding molecules to antigen-presenting cells. These enhance anti-tumor specific T cell responses by preventing T cell inhibition. Enhance anti-tumor specific T cell responses. So blocking T cell activation is actually enhancing anti-tumor specific T cell responses by preventing T cell inhibition. Okay, so taking away some of the communication between the T cells. And you remember we have a Treg. Don't forget about T regulation cells that down regulate T cell activation and T cell response. So knowing that, we have ipilimumab is directed against the CTLA4, the cytotoxic T lymphocyte antigen 4 for treatment of metastatic melanoma, and nivolumab and lambrozolizumab directed against PD-1 programmed death 1 used to treat melanoma, colon cancer, and other tumors. And then lastly, we have antibody drug conjugates. Deliver their immunotoxins directed against TSAs. Anybody want to jump on TSA and tell me what that is? That's an easy one. TSAs. Shouldn't have to be looking it up. All right, TSA. Has the transportation safety. So whatever they are, right?
Isn't it tumor-specific antigens?
Yes, that's the easy one. TSA, tumor-specific antigens. The antibody drug conjugates deliver potent toxin molecules directly to the tumor cells. So antibody drug conjugates. Brentuximab, Vedotin, right? An immunotoxin directed against CD30 antigen used to treat Hodgkin lymphoma and systemic anaplastic large cell lymphoma. And what do we know about Hodgkin's lymphoma? Has anybody heard of that? It's a good one. Why would a lymphoma be good? And I'm giving good as a relative term, which means that it's treatable, that it's curable, right? Hodgkin's lymphoma, that's 90-something%, I think, survival rate. Maybe because of brentuximab. Trastuzumab, DM1, an immunotoxin directed against the HER2 antigen, again, breast cancer, for treatment of HER2 positive metastatic breast cancer. So I'll give you one example of this immunotherapy. I have a salesman back in the day when I was ordering equipment for labs, and he came in. I got to meet him. He was a great guy. I spent all my money with him. I let him, we just did all kinds of business. But anyway, he was working for Fisher, and then he ended up with Dade Bearing, and he came to us and let us know that he had stomach cancer, and just didn't know if it was going to be a good outcome or not. And this was years ago. And then he came back and said, guess what? With all the breast cancer research, that the antigen of his tumor in his stomach was the same marker as a breast cancer tumor that had a immunotherapy treatment for. So when you think of research in one area for carcinomas, say Susan G. Komen, hey, it's all breast cancer, it actually can lead to other discoveries and other treatments. So luckily, he's with us today. His name's Bill Chrisman. And it's because he had a tumor that there was a treatment for the antigen marker in a therapy that he could just be given the infusion of the monoclonal antibody to go against his stomach cancer and to eliminate it. That easy. Okay, he was, that's what I mean by good news. So that is our monoclonal antibodies, and that is definitely a wave of treatment for what we're doing today. And that is directing the antibodies against antigen, tumor, TSAs, tumor-specific antigens, and letting the immune response have its way once they get there. Okay, so you're helping your immune response, that the tumor may have been avoiding it, as we talked about, going into its elimination, or what was the equilibrium, or eliminate, or what was that? Escape. So if we have a tumor that has escaped our immune system, then this may be the end result to get rid of that one. So definitely a player in treatment. So it is coming down to our adoptive immunotherapy. This was from your text. This is the last little bit. This is 17.8. This is immunotherapy with tumor infiltrating lymphocytes, TILs. Tumor infiltrating lymphocytes. The patient's tumor is surgically removed and cut into fragments. So a surgical removal of the tumor, cutting it up, which are cultured in vitro with IL-2. The cultures are screened for lymphocytes with potent anti-tumor activity. Positive cultures are expanded further in the presence of IL-2, are infused into the cancer patient. Before infusion, the patient has been treated with a high dose of chemotherapy or radiation to deplete the immunosuppressive cells. Okay, so we're actually taking the tumor out of the body here, growing it outside the body in the presence of IL-2 to what? To find, what are we finding? The lymphocytes with potent anti-tumor, right? And then putting those back into the patient, reinfusing after we do a lymphodepletion, and then going after what tumors was left. Okay, so if that is a neat way of thinking of how we're taking what we know about our immune system, tweaking it, and then releasing it back onto the body for treatment and possibly curing a patient of cancer. Okay, so definitely some cutting edge stuff. Definitely hopefully some stuff that you will carry with you. And we do see a chimeric antigen receptor at the very end of our chapter here. So you have a study guide, clinical application of tumor markers. You have some case studies, but the screening, diagnosing, prognosing, and monitoring, and they use the prostate-specific antigen, the HER2, and CA-125 in that list. So hopefully you've got enough out of this that you'll know at least something when it comes to tumors and kind of the way we look at them. And you will start off with the basic of screening for the markers on your patient, drawing blood and running those markers. And then maybe, who knows where you'll end up. You may be up in a lab one day doing this work with immunotherapy, producing tumor in, what was it again, TILs? We don't want to forget that. It's a new one. What's the TIL?
Tumor infiltrating lymphocytes.
Tumor infiltrating lymphocytes. So we're actually getting the best lymphocytes ready, putting them back into the body to go after the tumor of a melanoma patient. So definitely hope. But this is when you say, oh, we're spending money on cancer research, what are we doing with all this? This is what we're developing. We're developing strategies and treatments that can hopefully eliminate, or not, I don't mean eliminate, but make it where we have good news. Like, hey, like 80% of our cancers are good news now instead of 20%, where we actually have a treatment, where we actually have remission, where we have survivability over a tumor itself. All right, so that brings us, we're pretty much to the end. We have summaries. So this is definitely a big chapter, and I haven't even looked at the test bank, so it could actually be something like 5. I don't know. I hope it's more than 5 questions in the test bank over this chapter, because we spent 3 days on it, and I think we needed to, because I set aside 3. I mean, I remember when I looked at this, I like, it's going to take us a while, even with all the intro that we had and all the stuff, because this is new. You probably have never dove into this info. And hopefully you got something out of it. All right. Are we gonna do our, did Miss Bednar get mad that y'all didn't like turn on your cameras?
She said she was upset that we turned them on for you, but
Did you
not
turn
for
them on
her.
for her, or y'all still letting me be special?
No, I mean the
Y'all
three
didn't turn them
that,
on?
unless
Huh?
I missed somebody this morning, there were only a couple.
Oh, that means everybody has to turn them on. Let's go. We're gonna do this every day. All right, we got 3. There's 4. There's 5, 6, 7, 8. All right, good. Y'all getting quicker at this. Yay. All right. And I'll give you a 1, 2, 3. Okay. All right. And Josh, there was something wrong with Josh's video last time, so we will. Josh, you gonna be good, or you're out still? All right. So, all right, Hallie, I can't see anything but your eyes. And see, I've seen you with face mask all semester, so let's go a little bit higher. All right, 1, 2, 3. Yay. All right. Great to see you guys again. Hopefully everything, oops, we have friends. All right. See y'all tomorrow for micro. Take care.